Hello, welcome to OffBlueMedical. Today we will discuss impairment, misconduct, and cultures within the topic of ethics. So to get started today with the topic of an impaired physician. So an impaired physician is a physician who is unable to practice medicine with a reasonable skill and safety to patients because of a physical or mental illness, including deterioration through aging or depression, which is more common, or excessive use of alcohol or abuse of drugs, which is even more common. So the common causes of impairment is going to be substance use disorders such as alcohol, prescription opioids, mental health conditions such as burnout, depression, anxiety, bipolar disorder, physical illness such as a chronic disease or neurological disorders, cognitive decline, such as age-related memory loss or dementia. So you should ensure that the colleague does not continue to see patients while they are impaired. You should ensure that they don't treat a patient while they are impaired, because they clearly do not possess the right mind to do this. So if an impaired physician will be treating a patient, you should ensure that they don't see the patient, and you should report the physician to the physician health program. If the physician refuses, then they will be reported to the state medical board. So for negligence, which is also called here medical malpractice, it's a failure to meet a standard of care. So you must prove that the provider owes a duty to the patient, and that duty is breached, then a damage results, and the damage is caused by the breach. So physician misconduct is any behavior by a physician that violates professional, ethical, or legal standards. There are many types of misconduct, including sexual misconduct, which is going to be any sexual contact or harassment involving patients or colleagues, negligence or malpractice, which we talked about, substance abuse, boundary violations, such as inappropriate relationships with patients, fraud, falsifying records, billing fraud, and accepting expensive gifts. So here the rule for gifts for the USMLE is going to be that, let me write it here. So for gifts, you should only accept small monetary values. So and by monetary values, I don't mean that you should accept like $10. You should never accept even $10. So first off, you should never accept large amounts of money. You should never accept small amounts of money. So any kind of cash is not allowed. But by monetary value, a low monetary value which is allowed is like cookies. So if you treated the patient and they go home, and the other time they see you in the clinic, or in the office or in the hospital, they bring you a box of cookies, then that's okay, because its monetary value is likely to be like $10, $5. It's not going to hurt the patient financially. It's not going to affect the relationship, the physician-patient relationship. So first off, you should never accept cash, any cash. You should never accept it, because that will influence the physician-patient relationship. The second rule is that if you do accept a gift, then it should be a low value gift, such as cookies, tomatoes, oranges, so something that's not expensive. And you should always also consider the motive behind the gift. So you should always think, why did this patient bring this gift? So if you treated a patient and they went home, the next time they came back, they see you, they bring you a box of cookies, then that's a general appreciation gift. It's a low monetary value, and its motive is just the person is being good and kind and giving you cookies. But if it's a psychotic patient, for example, a mania patient, you treat them, they go home, and then after like just 1 day, 2 days, they bring you very expensive watch. Then you should not accept this, because the motive here is unclear. So did you actually, first off, the gift is very expensive, you should not accept it. Second, you don't know the patient's motive. So is this patient actually in the right and clear mind, or are they still under the influence of mania? Their thinking is not right here, so you should not accept it. So you should always think of these conditions. You should never accept cash. If you do accept a gift, then it should be a low value gift, and you should always think of the motive. And you should always never accept gifts from companies that are likely to influence your thinking. So if a company comes out and tells you, okay, we will give you money to prescribe this drug, then you should not accept this. So for improper prescribing, such as prescribing drugs inappropriately for non-medical reasons, this is also not allowed. And any unprofessional behavior is not allowed, such as bullying, harassing staff, or harassing patients. So the duty to report physician misconduct is mandatory. You should always report any physician misconduct you see. For romantic or sexual relationships, so first off, romantic relationships with current patients are always unethical. They are always unethical. You must report any sexual misconduct or suspicion to authorities. And before any romantic or sexual involvement with a patient, you should end the patient-physician relationship, and you should avoid relationships with anyone influencing the patient care, such as a spouse, parent, or guardian. So if you are treating a child and you wanted to date, let's say, one of their parents, then you should not do this, because this is unprofessional, it's unethical. So some suggest waiting 2 years after termination of a physician-patient relationship before beginning a romantic relationship, though this rule is also controversial. So this entire topic is controversial. So, but this does not apply to psychiatry, the waiting 2 years after termination of a relationship to begin a romantic relationship. This does not apply to psychiatry. So psychiatrists should never engage in any romantic relationship with former patients, even if they saw them 10 years ago. So this topic is controversial, but what's clear is that any current patient, if you have a relationship with them, then that's unethical. The first point is the most important point. Any romantic relationships with current patients are unethical. So for sexual harassment, this violates rights and trust of the patient. This is unethical. It includes unwelcome sexual advances, any requests for sexual favors, and any other verbal or physical sexual acts, and you must report to this or any suspicion of this to the state medical boards. So for conflicts of interest, there are several practices to avoid. First off is going to be kickbacks. This is going to be accepting payment or any form of compensation for referring a patient. So this is illegal under the anti-kickback statute. And any problematic self-referral, which is basically if you own a facility, let's say you own an imaging center or a lab, and you send the patient to that facility, then this is a practice to avoid. You should not do this. So this is heavily regulated by the Stark Law, and you should know what a Stark Law is. So referring to a friend is unethical. So if you choose a specialist based on a personal relationship rather than their clinical excellence, you should avoid this. And reciprocal referrals, where you say, okay, I'll send you patients and you send me, this is not good, and you should avoid this practice. So there are many cultural issues, and there are many areas where cultural differences impact care, such as in communication. For example, if you're treating a patient who does not speak in English, maybe they speak in Japanese, maybe they speak in Spanish, maybe they speak French or German. So there are language barriers, nonverbal cues, and style of directness. Some patients could be direct, some patients aren't very direct. And decision making, the role of family versus individual autonomy. So in some cultures, individual autonomy is very important, and in some other cultures, like The family acts as a single unit to make decisions for a person, or maybe the oldest person in the family makes decisions, so you should always take this in mind. Health beliefs, so some patients have different understandings of their disease causation. Sometimes patients use traditional or alternative medicines or herbal medicines. Trust, so some patients have prior experiences with the healthcare system, they may not have too much trust. End of life care is beliefs about death, dying, and the afterlife. So some patients experience problems with this. Some patients are afraid of dying, thinking there's nothing after death. Some patients don't really get any fear about dying because they feel like they will go to heaven, or they have any afterlife thought. So it differs between different cultures and different religions. It all differs, so you should know how to deal with these. And I'll tell you how you should deal with these. But there's a very important point, which is communication. So when you communicate with a patient who is not fluent in English, you must wait for an interpreter unless it's an emergency. So you should not rely on a family member. A family member is acceptable only in an emergency when no other option exists. So the best rule here would be to wait for an interpreter, a physical. They will physically come and stand, and you will talk with them and translate. They will translate for you. If it's not available, then you should book an online interpreter, such as via a Google Meet or a Zoom or just a phone call or a video call. So you should do this if the interpreter cannot come in time. If it's not, if it's an emergency and the family member knows how to speak, then you should do this, but only if no other option exists, such as a physical interpreter or an online interpreter is not available and the family member knows the languages, the two languages, let's say English and Spanish, then it's okay to do this, but you should document it. Always document. So the best practices would be to ask and don't assume. So you should ask what's most important to you. Is there anyone else you would like to include in this conversation? You should use professional interpreters and never rely on family members, especially children. And you should show respect, acknowledge the patient's beliefs, even if they differ from your own belief. And practice empathy, so you should always try to understand the patient's perspective. Okay. Now we're going to discuss some cultural syndromes which are rare. To get started, we will discuss Down syndrome. So this is primarily seen in men in South Asia, such as in India, Bangladesh, Sri Lanka. And this is characterized by severe anxiety and hypochondriacal concerns about the loss of that, which is going to be a fluid believed to be semen. So patients believe this loss causes physical and mental weakness. So they feel like they are losing this fluid, and this fluid will make them weak. So they get very anxious. Koro is found in Southeast Asia, particularly China and Malaysia. So it's an intense, often panic-driven fear that one's genitals are retracting or shrinking into the abdomen, which is believed to be fatal. It can occur in both men and women, with the fear in women of nipples or labia retracting. Amok it originates in Malaysia and parts of Indonesia. So this is a sudden, unprovoked episode of homicidal rage followed by a period of amnesia. So these syndromes are most important. Less important syndromes are going to be brain fog, which is basically brain fog. This is seen primarily in West African students. It's a reaction to academic stress, presenting with headaches, brain fatigue, and difficulty concentrating. It's attributed to overworking one's brain. Ghost sickness is basically a preoccupation with death and the deceased, often accompanied by weakness, dizziness, anxiety. So symptoms are often triggered by a disturbing event or a dream about the dead. And the evil eye, which is popular, it's found in Mediterranean and Latin American cultures. It's a belief that the person with the evil eye can cause misfortune, illness, or even death to another person just by looking at them. So its symptoms include fatigue, fever, and a general feeling of being unwell. And Wendigo psychosis is a Native American syndrome. It's a fear of becoming a cannibalistic monster who has a desire to eat a human flesh, and this is often triggered by food scarcity.